I'm Bornali Kundu. I'm the functional neurosurgeon and epilepsy surgeon here at MU. Just a little bit about myself. I've done exclusively movement disorders, meaning Parkinson's and essential tremor, as well as epilepsy surgery for the last 3 years, and I've been a physician for 10 years now. I did, as was mentioned, 2 years of fellowship training in movement disorders, Parkinson's disease, DBS surgery, as well as essential tremor surgery. And I also did my undergraduate in biomedical engineering, so I've just been really interested in devices, implanted devices, and how they interface with the brain for a long time now. And also my PhD, I did a PhD along with medical school, and that was in looking at cognition and also brain stimulation. So love to talk to any of you at any time about these things. Okay, so I probably don't need to educate this audience too much on this, but just to get us started, in Parkinson's disease, what's really going on? Well, the truth is we don't totally know what's going on, but one of the main things that's been described is that there is a loss of dopaminergic neurons, meaning neurons that produce this chemical called dopamine, and that is produced down here in the brainstem. So when we do various types of cognitive functions, dopamine is used a lot of times for reward circuits, motivation, planning. And what happens in Parkinson's disease is there's a loss of these neurons, so they no longer produce dopamine. And so that then initially generally affects movement, like walking, balance, fine motor movement, things like that, and then it may later progress to things like cognition, like how we think. And one of the main medications that we use to treat Parkinson's is Sinemet or levodopa carbidopa, and what that is we're essentially replacing that lost dopamine. So in Parkinson's, there's generally two types of categories of symptoms. One are the motor symptoms, and the other category are actually non-motor symptoms. And so motor symptoms, and that's generally how we define Parkinson's, is a combination of these three or four symptoms, which include tremor, and that is generally a resting tremor. Sometimes it can be a movement tremor as well as a resting tremor, so that means when someone's trying to do an activity. Also slowness of movement, which is bradykinesia, and muscle stiffness or rigidity, and something called freezing of gait. And so that means that when patients are walking, sometimes this is associated with doorways or certain areas or walking on a sidewalk and making a turn, but patients might have trouble getting going again. They'll be frozen for a little bit of time. Then there's non-motor symptoms, and so this is a real large range of symptoms. These can include things like thinking, cognition, but also sleep. So sometimes patients may find that they're acting out dreams, for example. Sometimes they can involve mild hallucinations like seeing shapes or things that, not necessarily full-on objects hallucinations, but shapes and shadows that might not actually exist. There can be blood pressure changes, generally low blood pressure. Also, loss of sense of smell, and that's something that happens pretty early. People might notice in their 50s, 60s that they can't really smell as well as they used to. And constipation, sort of GI symptoms. So what does a general care pathway look like for patients with Parkinson's? So initially, a diagnosis needs to be made, and that can actually take years because symptoms can be pretty subtle in the beginning, and people might have a couple different diagnoses in the beginning before it becomes more clear that the diagnosis is Parkinson's disease. So that may be symptoms like rigidity, tremor, slowness of movement, And it might be dystonia, like having cramping in your feet or arms, things like that. So usually a primary care may refer to a neurologist, and generally a movement disorders neurologist or other neurologists trained in this, and medications are started first. So that's always our standard. We start with medication management, and that generally works really well. So as I mentioned, the Cinemed or levodopa, carbidopa, and there's all different kinds of formulations of that are started first. And that can control generally motor symptoms well in the beginning. Over time, what happens, however, is as the disease progresses and symptoms become worse, patients may find that their medications don't work as well for as long. And so they're having to take medication more often or more medication, up to maybe 4 times a day or 5 times a day, which can be really burdensome and difficult to keep track of. And what happens is people's symptoms really fluctuate. They go up and down. So patients will take medication, they'll kind of overshoot, and they might have extra movements for a bit, and then when the medication has a sharp wear-off, people can become feeling frozen again. And so there's this really wild kind of fluctuations that start happening. That is really when patients get referred for deep brain stimulation surgery, because what DBS does is it helps flatten out those fluctuations that patients have with their medication and helps people have longer on time. Okay?
Yeah. Alexa.
Okay, so some of you may be familiar with this. This is just a simple diagram, and if I see you in my clinic, we have models and things, and maybe the vendors have some models too of what the devices actually look like. But this is the general components of a DBS system, and several different wonderful companies make this device, and they each have their own little nuances, but these are the main pieces of it. So deep brain stimulation systems are implanted devices. They have a couple parts.
What?
There's an electrode that goes in the brain, and then there is a wire that's essentially an extension cord that goes down and connects to a battery in the chest. We call it the neurostimulator. And it's really similar to the concept of a pacemaker, if you have or know other people that have pacemakers. And in fact, that battery was first devised or engineered, inspired by pacemakers. So what happens is this electrode is delivering a really low level of current to a particular target in the brain. Actually, there's 2 targets we consider. And it generates an electric field. And the mechanism here is probably very complex, and lots of scientists have been working on it for a long time. But one of the prevailing theories is that when patients have Parkinson's or essential tremor, there's an aberrant brain circuit, an aberrant set of connections that are always happening that cause problems with motor function. And what DBS does is it's injecting noise. Sometimes people refer to as jamming the system. So it's trying to clear up the signal so that people can move better. And so that's what I refer to here as calming a noisy signal. There's other concepts like it stops activity in an area, but it's actually a lot more complicated than that. So what happens is that this generator is able to generate, and all 3 companies that make this device, their batteries are able to do this. So they generate currents and stimulation in different frequencies and pulse widths that are then delivered to the brain to allow for this change. And when someone initially gets that device, we go through a process of adjusting stimulation parameters based on symptoms, and that can take several months. Okay, so what can DBS help with? Well, I want to emphasize here that DBS really helps mostly and almost exclusively with motor symptoms. That's what's been characterized best. It may help with other things, but that hasn't been shown really clearly in the literature yet. And so that's what I would talk to you about if I saw you in clinic. And that the patients that respond best are those who have primarily motor symptoms. So that again is a resting tremor with maybe a combination of movement tremor. The rigidity, so cogwheel rigidity is something we call it, or if you have your neurologist that moves your wrists around every clinic visit, that's what we're testing, the rigidity. And slowness of movement, so, getting up from a chair and walking anywhere really. So that bradykinesia. And it generally does not help with things like maybe emotional dysregulation, if you're feeling off in that manner. It generally doesn't help with GI problems. It doesn't help with the loss of sense of smell, hallucinations, things like that. Okay, so what in general is involved with getting this DBS implant? And of course, we talk a lot more in detail in clinic about this, but I'll give you the brief overview so that you have an idea about what it involves. And I think that this is pretty standard. It's what I do, that's what I trained with, and I think that's pretty much how all my colleagues across the country do this surgery with very little changes. So the one big thing is some centers or some people do DBS surgery asleep, and sometimes it's done awake. Some centers do both. At our center, because of the equipment we have, I primarily prefer to do it awake, and I'll tell you why, but I can also do it asleep in certain exceptional situations. So I think that's kind of a big question sometimes people have. So the big steps are, first, step one is electrode placement. And so that is, we call it phase one. Step two, which happens a week later, is battery placement. And so what is the electrode placement? Well, that is the open brain surgery part. And what happens is I generally have to place a frame on the head, and we use a lot of local anesthesia to allow us to essentially screw a metal frame, onto the skull. It feels like pressure. It sounds pretty scary, but people have been tolerating this surgery for a long time. People in their 50s, 60s, 70s, and even 80s. So people generally can tolerate this pretty well. And I wanted to mention that even though this is really amazing technology, it's actually a really old surgery that's been around for 30, 40 years and essentially hasn't changed much because it worked so good to begin with. So lots of people in the world have these systems, and they had them implanted in the way that I'm describing. So we put a frame on, and then we get onto an operating room bed, kind of in a beach chair position, get a CT scan, and then I do have to shave a little bit of hair, and we have to make 2 incisions, and we have to drill 2 holes, or 1 hole, depending on how many electrodes are needed. And it kind of feels like being at a dentist office. That's what I like to describe it as. You can hear the drill, but it doesn't really feel like much. 2 holes that are about the diameter of a dime, okay? And then we place the electrodes. And that's where I need audience participation. So the patient, you can take a nap during most of it, but then during that one part, we like to test where the electrodes are. We can do the implantation. I can do it without you participating, but it's generally a little better if you can participate. And I'll move your wrist around just like your neurologist. So moving the wrists around, finger to nose testing, things like that you do in clinic. We'll make sure that the electrode's in a good place, and then we lock it in. And then we go to the other side, and then you're done. You take the frame off. You're usually in the hospital for about a night or 2, and then you go home. And then come back in a week, and we do the battery placement outpatient, meaning you don't have to stay overnight. And that's where we essentially attach an extension cord, and it's all under the skin, to the chest where the battery sits. I guess the other thing I'll mention is people wonder, when will we be programmed afterwards? Usually we get programming done. I don't do the programming, that's with a neurologist. And that happens several weeks, 3 to 4 weeks later. And that's because after surgery, there's some changes that happen in the brain around the electrode. And so it wouldn't be helpful to program before that time because things haven't really healed up. Okay, So is DBS right for you or your loved one? These are just some pointers, but again, I think talking to your family care doctor or neurologist is really important. So generally, patients have been diagnosed with Parkinson's for several years. There's some data to suggest early stimulation is helpful, meaning if you've had the disease for maybe 3 to 5 years, it's good to consider DBS early, because what it is it's really a quality of life surgery. It doesn't stop the progression of Parkinson's, but it essentially gives patients better mobility for an increased amount of time. So I kind of describe it to my patients as setting the clock back about 10 years. So you're getting better movement, your medications are working better for you. You still have to take medication, usually. So there are definitely exceptional cases where DBS took care of everything and nobody has to take Cinemet. But the patient does not take Cinemet, but that's a rare situation. So in that situation, DBS is really helpful. When medications aren't working well anymore, you're having to take medication 3, 4, 5 times a day, and it's becoming really burdensome. I generally encourage people to consider DBS when they're still active. So it's really not a good salvage therapy, so to speak. So if someone is totally wheelchair bound, if a patient has a lot of disability, then DBS is really not going to be very helpful. It's helpful when generally people are still mobile, trying to do activities. Maybe they're out and about in town, out and about in their house. That's kind of when it's really helpful. And again, patients that are mostly struggling with motor symptoms. So it's really not helpful for those cognitive deficits, GI issues, bladder, bowel issues, things like that. Okay, I kind of touched on this earlier, but what can we expect? So DBS helps the medication work a little better. People may decrease their medication, rare cases maybe stop medication or take off a few medications and maybe just take 1 instead of 3 medications. And as I said, there's this fluctuating symptom, and DBS helps flatten that. So you're not overshooting the goal and then undershooting when the medication wears off. Most patients have a pretty good improvement, and as the audience knows, Parkinson's looks different in every patient, and it's really interesting that way, that it presents slightly differently in every person. But in general, people have a good motor improvement, around 80% of symptom improvement, and that's especially true if you felt like medications changed your symptoms. So if Cinemet or levodopa, carbidopa, or its equivalent formulations didn't change your symptoms very much, then DBS may not really help either. And then the last point is, people feel more mobile, more stable. It's a quality of life surgery. So it doesn't change the progression of the disease, but it helps kind of give patients a window of better mobility. Okay, so those were the benefits, but in all surgical decisions, we have to talk about risks as well. And so the risks of this surgery are, they exist, but they're small risks, but they're significant if they were to occur. And that's why it's really important to think about that. So there is a 1% roughly chance of bleeding when we place electrodes. And I do, and my colleagues across the country, as I said, we all use imaging to plan electrode trajectories. And so if you were to undergo this surgery, we'd have you do quite a bit of imaging beforehand. But sometimes there are microscopic vessels that are just not imaged well. And so generally there's a 1% chance of bleeding. There's actually a far less percent chance that a stroke would be caused, that you would have a permanent deficit like paralysis or inability to speak. That's really rare, but could happen. The other risk, which I think is more significant, is chance of infection. And across the nation, it's about 3%. Personally, for me, it's about 1%, but it's not zero. So we do a lot of antibiotics during surgery, after surgery, and a lot of wound care instruction. And so infection risk is low, but it's not zero. Other things are side effects that can happen just with stimulation. So sometimes if someone's current is required to be really high to have good motor control, sometimes that can also result in slurred speech or potentially balance problems. And the reason is because that area in the brainstem that I pointed to earlier has a lot of fibers that are really close by to the target. And so there's just not a way around that. And the way to help that is sometimes decreasing stimulation amplitude or working with our industry partners to help with programming, having the neurologist program in such a way that you're optimized. Or maybe you have several different programs, one for knitting, one for taking a walk, one for other activities.
So good.
All right, so again, the device is totally under the skin, so no parts of it should ever be exposed. And if you have a DBS and there's any parts exposed, please come see me because we should work on that. Yeah. Okay, I think this is getting to the end of my slide deck, but one thing I did want to mention, and it's a plug for MU, it's a plug for just seeking help at a hospital system that has performed these surgeries in the past, because experience does matter, and that's why I did fellowship training for 2 years. So it's important to find a surgeon who does this all the time and thinks about this all the time, because the surgery itself involves many steps, and it's not just the surgeon. In fact, it's really the staff need to know what they're doing. The physical therapists need to know what they're doing. We're affiliated with RUSC, which has actually physical therapy specific to Parkinson's patients. And so it's really helpful when you have a whole team that's familiar with Parkinson's disease when you're seeking a center to do your surgery or just care in general. And so the next bullet point is talking about that. So all the way from in the ICU, so my patients spend one night in the ICU, and the ICU doctors are familiar with what I want my patients to have. As you guys know, taking medications on time is really important. So those are things that I really emphasize when other doctors are helping me take care of my post-op patients. Patients have to get their medications. Otherwise, people feel frozen, things like that. So it's important to try to find a center where we do that all the time, just like at MU. And that's been shown in literature too, helps with outcomes. Okay, final thoughts. And of course, please ask questions. I'll be here till noon. I think it's good to get information early. I would not wait till you're in a situation that's really desperate. I think having information early and from reliable sources is really important. So conferences such as this one. And then you can kind of think about and meet other people that might have a DBS system, meet a potential surgeon, and just have that in the back of your mind if you're considering this option. Getting a consultation, seeing me in clinic does not obligate you to have surgery. And in fact, I will tell you if I think you're too early, because I want people to have the best outcomes. But I will say that I think a lot of times patients may wait too long because there's maybe not enough information out about having a brain surgery, which is definitely significant. And so don't wait too long. Ask your neurologist or your family med doctor, and they can get you in contact with our team. And we can get you the resources that might be helpful. Okay, so that's all I had, and I'm not sure how we're doing on time here. Okay, I'm a little early, but I think that we're going to do some transitioning, so you'll have some extra time, and again, I'm around if you have questions.